for the colleagues who have joined the Health Technical Webinar. This is the seventh in the series of the technical webinar hosted by the Asia Pacific Regional Office. In today's webinar, we will be mainly discussing around the second wave and the Red Cross, Red Crescent preparedness and response to for the second wave. So the next 1 hour, we will see a variety of presentation from the Asia Pacific Regional Office. As per the tradition, we will start with a general introduction and current situation in analysis of COVID-19, how the virus is behaving in the region. It will be followed by a presentation around the second wave, what it is, and how a Red Cross, Red Crescent national societies can be better prepared to respond to a second wave, which many of the epidemiologists and scientists believe can have more detrimental effect than the first wave. And we will also see some comparison with the previous pandemic, what type of lessons can be drawn from that. Our pandemic preparedness coordinator, Nick Prince, will take us through that session. And then you'll have around 15-20 minutes for the question regarding the situation, what is happening now, different types of activities that the Red Cross Red Crescent has been doing, and also potential question on the second wave presentation can be addressed to us. And you have myself, Nick, and also John Fleming to try to answer as much as question as possible. Then finally, we'll have a closing remark and key messages from John Fleming, Head of Health for Asia Pacific Regional Office. So this is how the next 1 hour will unfold. Okay, let's start with our famous Asia Pacific dashboard. I do hope by now most of you are visiting the dashboard and trying to get and situation analysis what is happening in the region and also in the country of your interest. So at this stage, we have 27 countries with confirmed COVID-19 cases, with 2 countries with established community level transmission, 18 countries with cluster of cases, and 7 countries with sporadic cases. At this stage, if we go purely by number, it is India, Pakistan, Bangladesh, and Singapore with most number of active cases, which is driving the pandemic in the region. And if you see the number of deaths, it is India, Indonesia, and Pakistan, which has highest number of deaths in the Asia Pacific region. But if we compare this with globally we have almost more than 4.7 million confirmed cases and more than 318,000 deaths globally due to COVID-19. This is truly a multi-center pandemic which started from China. Now the focus is in Europe and Americas with large number of cases there. But the recent trend is showing we are also peaking in the areas with number of cases, and the cases are now start increasing in those countries with big population. So as the day progresses or as the time progresses, we can see more cases emerging in the Asia Pacific region. If we see this graph, which is also available in the Asia Pacific dashboard, the trajectory of both total number of confirmed cases and also the active cases still showing an upward trend. There is a good news that at this stage we have more number of recoveries than the active cases. Since the beginning of pandemic in the Asia Pacific region, more than 190,000 recoveries has happened from COVID-19, and at this stage there is around 161,000 cases. However, in the past few weeks, there have been some of the red flags, and the cases are now start emerging, or there is a surge of cases in countries with weaker health system, in fragile states, or in area where there is large density of population and people are living in poverty as well. So in those cases or in those instances, the virus can very quickly spread where we cannot do the social distancing, proper hand washing, etc. And people are malnourished and the immunity is less. that it gives a perfect ground for the virus to spread very rapidly. So that is also one of the major concern. Secondly, we have also confirmed now 5 cases in Cox's Bazar, in the world largest refugee camp. So the massive testing is now underway to see what is the extent of the spread of the disease in that camp. Um, Saying that, we have to see, like WHO and other countries are and other specialists are time and again saying the only way to defeat this virus is isolate, test, and treat. So if we see the testing, Asia Pacific do present a very diverse picture. We have Australia, Singapore, Republic of Korea, Malaysia on one hand, where we have number of testing in a very good shape, like they are testing around 15 to 20 people per 1,000 people as of the data of 16th May. But at the same time, we also have countries like Myanmar, Indonesia, Nepal, and Bangladesh, where the testing still need to be scaled up in a biggish way so that we know the true extent of the virus or true extent of the disease in the region. The thing is that, like these countries like India, Bangladesh, Nepal, Indonesia are trying to massively scale up their testing capacities in near future, and we might have a very different picture in days to come once those testings are really scaled up. Um, at this stage, like Asia Pacific national societies are doing a tremendous job in health promotion, health awareness, providing clinical services, ambulance service, blood service, etc. But like by seeing the extent of the pandemic, there is a decision in the Secretariat to again revise the appeal, which will be under the 3 major heading, and one of which will be around health and wash. And in the health and wash, these are the primary areas that we are suggesting where national society can really scale up their activities, be community health awareness, hygiene promotion, establishing of water station, mitigating the secondary health impact of COVID-19, primarily focusing on vaccine preventable disease, vector-borne disease, tuberculosis, etc. It will be followed by also really strengthening risk communication and community engagement, supporting government as per the mandate of the National Society to detect, test, and isolate COVID-19 cases, provide some social emergency services in the quarantine facilities, like providing food, water, assisting the government in different types of activities in such quarantine facilities. Psychosocial support remains one of the major pillar in the COVID-19 operation, and people are very anxious about the future, what is happening. People are getting tired with the lockdown, with lack of livelihood, and also the frontline workers working in hospitals and other sectors as well. So the psychosocial support remains as one of the important work that the National Society can do. We from the Red Cross, Red Crescent, or IFRC is trying to develop together with the Hong Kong Red Cross branch of Red Cross Society of China, and with close collaboration with PS Center, a virtual platform for mental health and psychosocial support. This is just is at an incipient stage at this stage, but we would really like to build this capacity on. There is also big push from different national society across Asia Pacific on is how Red Cross as an auxiliary to the government can strengthen the health system. One, by upgrading the hospitals and clinics and reinforcing the already existing health facilities by supplying staff, PPE, equipment to provide better treatment for COVID-19 cases. Some of the national society who already have clinical experience are also opening their own isolation and treatment center, and also some corona treatment hospital as well. COVID-19 diagnostic lab is also getting, some of the national societies are getting involved. It is a biosafety level 2 lab, and like national societies like Philippines Red Cross and Indonesia Red Cross are thinking to work more on increasing the national capacity by involving in such diagnostics as well. there is a big push around how we can scale up the home-based care around the treatment of the mild cases. If we go to the worst case scenario, the health system might not be able to really hold all the cases, and mild case must be treated at home. In that, how the Red Cross volunteers and staff can play an important role in building the capacity at the community level to cater the need of the mild cases as well. And finally, how we can scale up the core Red Cross, Red Crescent capacity, that is around the ambulance service, around the wash, and around the blood service. So this is where we are thinking how we can really scale up the capacity. When you are revising, working with the National Society around the National Society Response Plan, do consider these points where around the Red Cross, Red Crescent response for COVID-19. Now I will just hand over to Nick, and maybe I will take out this presentation and he can upload the one and take you through the second part of this webinar, which is on the second wave. Over to you, Nick.
Thank you, Dr. Abhishek. Just going to share my screen. Okay, just before we start, can I get confirmation that you have the presentation there?
Not presentation, but we can, I think, see your screen for sure, but the presentation is not there. Now we can see.
Great. Okay, thank you, Dr. Abhishek, and a great afternoon and a warm welcome to everyone who has joined this week's Health Technical webinar. As you heard, it's our 7th of the series, and today we're going to focus on the much talked about second wave and what would be the Red Cross, Red Crescent support. So just before we start, I'll just go through some of the key objectives today. So we'd like to understand what is meant by the second wave, understand how and why a second wave for COVID-19 might occur, experiences of the 1918 Spanish influenza pandemic, consider what could be the secondary impact of a second wave, and what needs to be done to prevent or reduce the risk of a second wave and secondary impacts. Before we start, however, I'd like to just acknowledge those who have provided the material and resources for this webinar, in particular to Gwen Ema, the Senior Officer Public Health and Emergencies in Geneva, from which I've drawn much of the material as well as from other sources. So let's start by helping to explain what is a second wave. Epidemics can come in waves, a bit like waves in the ocean that can build and end when they come rolling onto the beach. Sometimes the waves are like ripples that dissipate before making landfall. Others build and come crashing with force onto the land, shifting the sand and pebbles and moving everything in its path. After a while, the ocean becomes calm and seemingly at peace, giving a sense, at least to seafarers, that all is well. The calmness, however, can give false hope. Lurking beneath the waves, things are happening, and there are factors above and below the ocean and gravitational forces that will soon disrupt the calmness, bring us a new surge of waves, sometimes king tides with massive waves. Epidemic waves are similar in as much that they can be multiple, with periods of calmness or of a sense of normalcy between each wave. However, what is different is that unlike ocean waves, we have a degree of control on whether a second, third, or further waves will occur. Epidemic waves or surges can occur as long as there are key elements in place that allow the virus to remain active, have the ability to infect, and these elements are: 1, there are people carrying the virus unchecked circulating in the community. Secondly, there are people who remain susceptible to infection. And thirdly, people remain exposed to the virus. Removing one of these 3 elements will, however, lead to an interruption of the virus's ability to spread from one person to another. With nowhere to go, the virus will eventually peter out. So epidemics are not stationary. They either grow or they shrink. The direction in which they go will largely be based on the measures taken to control the spread, not just during the first wave, but sustained long after the first wave has dissipated. If you look at the graph representing the initial outbreak, measures to contain and mitigate the rise in infections will result in the epidemic reaching its first peak. Many countries have seemingly reached their peak, albeit with different levels of loss of life, suffering, overwhelmed health services, depletion of health workers, unemployment, economic distress, violence, and other what we term as secondary impacts. As the curve begins to flatten after reaching its peak, it will eventually descend, albeit at a slower rate than the growth. The overall goal of an epidemic response is to stop further transmissions of the virus. Without adequate control measures in place, the number of infected people grows exponentially. In countries having experienced large-scale community transmission of the virus that causes COVID-19, cases have grown exponentially, with the number of new cases doubling as quickly as every 2.5 days during the phase of the most rapid growth. Public health measures to reduce transmission, including physical distancing, quarantine, detection and isolation of cases, and surveillance, eventually work to flatten the curve. Experience with COVID-19 to date has shown that it takes up to 10 times longer for the number of new daily cases to halve on the downswing than it did for them to double on the upswing. For example, a country that experienced a doubling of cases every 3 days could take 30 days to see the number of new cases drop by half once the peak has been reached. An infectious disease outbreak can start by a single infected person infecting a group of people who are susceptible to the disease, who then go on to infect other groups of susceptible people. Can I just ask if people can turn off their mic? Would be great. Thanks. Depending on how the disease is spread and the rate of spread, exponential equals the number of days it takes to double, the rate will be a steep incline as seen in the graph, a doubling of number of cases every 3 days if it reaches its peak. Now, it was mentioned earlier on about the exponential growth rates, and here is an example in some of the selected countries in Asia Pacific. COVID-19 did not have the same starting point in each country. There are several factors that influence the rate and speed of its spread and the impact it has on individuals and communities, not least how the disease manifests in different population groups, taking into consideration age, underlying health issues, which can determine the level of seriousness of illness if infected. Whereas there are countries that have reached the first peak of the first wave, have witnessed a plateauing of, or even a downswing in cases, what we call the R number or the reproductive number, there are many countries that remain on the upward swing or trajectory of the first wave. Countries generally with strong healthcare systems or have a greater ability to implement enforced measures or have a society that are empowered to adopt the changes without enforcement will have a much better chance of flattening the epidemic curve and the ability to push down the level of infection represented by a downward swing. Examples are New Zealand, Australia and South Korea, who have strong healthcare systems with enforced behaviours. And then you have Vietnam and Cambodia, where community action and compliance, or overreaction as some have suggested, has significantly reduced and driven down the infection rates. Many of these countries are able to mitigate the social and the economic secondary impact of the enforcement through financial support. At the other extreme, countries with fragile healthcare systems have low testing capacity and high levels of vulnerability, large populations, high density living and wider gaps in wealth distribution and a displaced population living in environments that increase exposure to coronavirus will continue to see exponential rise as we are witnessing in countries such as Afghanistan, Bangladesh, India, Pakistan, the Philippines, Myanmar, PNG and Nepal, which is currently seeing an exponential rate of 4 days, which is at the top of the chart. Looking at the bottom of the table, you see that South Korea has a number of days it takes to double 70. So what leads to a second or further waves? Second waves occur when the three elements, that is susceptible people, contagious people, and opportunities for exposure, are not reduced enough, or when there is a change in population dynamics, or the virus itself exposes new susceptible people, or it introduces new infectious people, or when there are changes in the level of exposure. Or the virus is not completely eliminated from the population and there is a remaining large susceptible population. The virus will continue to circulate until it reaches a tipping point that will lead to a new exponential growth phase and reach a new peak of cases. The cycle basically repeats, but can be more devastating than the first epidemic wave. So this can be caused by where prevention, for example, physical distancing and control measures such as isolation, testing and contact tracing are ended before transmission is eliminated. When large public or community events are held, which can create a super spreading medium for the virus to infect a large exposed population, when there's a complacency or decreased physical social distancing. When the virus is reintroduced after elimination through human population movement, such as travel, return to work, forced displacement. Or if the virus mutates, as it did for the 1918 influenza pandemic, anyone having previously developed immunity would then be susceptible to the new strain. In this slide, I'm showing you where countries are in beating the virus. So those that are considered to be winning, those that are nearly there, and those that need to take urgent action. You will see that Singapore was initially doing extremely well and world leaders in getting on top of the epidemic. However, the virus was still in circulation and there was a susceptible community that were living in an environment that exposed them to the virus. In essence, this could be a second wave, a community who were either part of the initial response, not part of the initial response rather, or became a new interest to the virus. Similarly, South Korea had previously got on top of the virus, but a crucial element to prevent cross-infection was either removed too quickly or was not able to be sustained. Once there was a relaxation on social gathering that led to a cluster outbreak at a social venue, the response, however, would be to then quickly contain the cluster outbreak through contact tracing or isolation, as long as those who attended the social gathering are willing to be found. So is a second wave likely? And if so, how likely? A second wave is more likely when measures taken to control the epidemic are not so. The virus remains viable and there are susceptible people, contagious people, and opportunities for exposure. Herd immunity, 70 or greater % of the population for COVID-19 has not been achieved. Note that there is currently no evidence that infection will lead to immunity. And lastly, there is no effective vaccine. Infectious diseases spread via contact between an infectious person or people and susceptible people. In the absence of any control measures, an outbreak will grow as long as the average number of people infected by each infectious person is higher than 1. If people who recover become immune, which is still to be determined, the outbreak will generate a community of immune people. Once enough people are immune, the tipping point is reached and the outbreak fades away. When an outbreak is quickly brought under control by physical distancing and other public health measures, such as we've seen in many of the countries who have plateaued or caused a downward swing, only a small proportion of the population will have been infected and gain immunity. If the population has not achieved immunity, and if the virus is not entirely eradicated, enough susceptible people may remain to fuel a second wave of cases when controls are relaxed. This is the big danger in countries that have quickly controlled the virus, such as in Australia, New Zealand, South Korea, Singapore, Vietnam, and Cambodia. There are two general scenarios in which a second wave could occur in populations that have not achieved immunity through exposure or vaccination first. Firstly, if the virus is not eliminated from the population, it will continue to circulate amongst susceptible people, eventually reaching a new phase of exponential growth and a new peak. This can be caused by ending control measures like physical distancing too early and before the transmission has truly been stopped, and if surveillance systems fail to detect the small rise in cases that precede exponential growth. Secondly, if the virus has been eliminated, it can be reintroduced through human movement. For this reason, quarantine, point of entry screening, and enhanced surveillance are critical to rapidly detect imported cases and quickly isolate them from the susceptible population. In the context of COVID-19, a safe and effective vaccine administered to a significant majority of the population would change these dynamics. Still, no such vaccine is expected to be available for at least 12 to 18 months. Second waves can be caused by healthcare workforce shortage. So particularly in a mitigation approach, the lack of healthcare workers available to safely provide care for people ill with COVID-19 can increase infections in healthcare facilities and result in increased transmission in communities, as sick and infectious people are unable to seek care and therefore unable to appropriately be isolated from society. Finally, if humans develop immunity to the virus that causes COVID-19, leading the outbreak to fade away in communities that have faced very high levels of infection, the virus could mutate to the extent that the immune response developed by the human body does not recognize it, allowing a person to be reinfected. As the virus evolves, as it circulates within a given population, large-scale mixing of populations, such as through large-scale displacement, could bring a new strain of the virus to the population that has experienced an outbreak of a different strain. To date, research indicates that the virus has remained remarkably stable, and viral mutations have not been seen as having an impact on the current outbreak dynamics. However, this can change. So to answer the question, is a second wave likely? The answer, it depends on actions of governments, the ability to adopt and maintain measures, the ability to respond quickly to any outbreaks or clusters, the ability to test, the ability to counter the social and economic impact that will ultimately drive the ability to sustain some of the behavior changes. So what can we learn from the 1918 influenza pandemic and the waves that occurred during that pandemic? The 1918 influenza pandemic, the most severe pandemic in history, occurred in 3 waves. The first wave was in the spring of 1918, the second in the autumn of 1918 or the fall, and the third in the winter of that year until the spring of 1919. An interesting fact on numbers here, and probably most of you will know, is that more people died during the 1918 influenza pandemic than the total number of military and civilian deaths that resulted from World War I. While the global pandemic lasted for 2 years, the vast majority of deaths were packed into the highly fatal second wave during 3 months in the autumn of 1918. Often associated with the troop movements returning home after the war and the easing of movement restrictions such as curfews, the attempts to get back to normality, and susceptibility to infection due to the effects of the war on health, the nutritional status, and the social economic challenges post-war. Public health historians now believe that the deadly severity of the 1918 influenza pandemic's second wave was caused by a mutated virus spread by wartime troop movements. Outbreaks of the influenza occurred in nearly every inhabited part of the world, first in ports, then spreading from city to city along the main transportation routes. India is believed to have suffered at least 12.5 million deaths during the pandemic, and the disease reached distant islands in the South Pacific, including New Zealand and Samoa. In the United States alone, 550,000 people died. Most deaths worldwide occurred in the brutal second and third wave. Other outbreaks of Spanish influenza occurred in the 1920s, but with declining virulence. So I want you for a moment, or after this presentation, because we will share this presentation with the notes as well, to think about the three following points. How coronavirus spreads from person to person or people, what has been done to stop the virus from spreading, flatten the curve, and bring the reproductive, what we call the R number, to less than 1? What has been learned from what happened during the 1918 influenza pandemic? And then once you've thought about some of those questions, is think about the role of the Red Cross, Red Crescent movement in addressing some of these questions. Whilst you're thinking about those questions, let us just remind ourselves how the virus is spread from one person to another or a group of people. What we currently know about the transmission of COVID-19 is that the transmission occurs when the virus is passed from person to person by droplets. This happens when a person coughs or sneezes and you inhale the droplets dispersed, or when touching an infected surface and then touching your mouth or eyes before washing your hands. So generally, small size droplets are dispersed when you sneeze or cough, which can travel up to 10 meters depending on the airflow and humidity, and larger droplets can spread up to 2 meters. When exposed to air, the virus particles begin to dry up, which is why the further you are away from the droplets, the safer you are. When you are closer than 2 meters, the larger drops are still very viable and can be inhaled, or you come into contact with your eyes if you rub your eyes, nostrils, mouth with your infected hands. Droplets will eventually fall and then land on surfaces. This is when the virus can transfer from one person to another or several others. The virus does not become inactive when it lands on a surface. It can remain viable for quite a long time depending on the material of the surface. Estimates are that the coronavirus can remain active and therefore viable for infection if touched up to 72 hours or 3 days on certain surfaces. Human skin is ideal for a virus. It is organic, so that when the virus particles land on your skin, the dead cells on the surface interact with the virus. So when you touch, say, a steel surface with a virus particle on it, it will stick to your hand and hence get transferred onto your hands. If you then touch your face, especially your eyes, your nostrils, or your mouth, you may get infected. And as it turns out, most people touch their face every 2 to 5 minutes. So having thought about how national societies can stop a second wave or mitigate the risk of it happening or reduce its impact on those affected, the following must be part of the action. Breaking the transmission chain requires removing at least one element: the susceptible people, the contagious infectious people, and opportunities for exposure. The most effective response, however, tackle all 3 elements at the same time. Reducing the number of infectious population. This can be done through detection, such as community-based surveillance, active case finding in health facilities, testing, isolation of all the cases, contact tracing plus quarantine, point of entry, point of control screening. Removing or minimizing exposure, increasing hand washing points, promoting hand hygiene and coughing, sneezing etiquette, infection prevention and control IPC in health facilities and community gathering points such as markets, and community risk engagement and communication. Lowering the number or protecting those who are susceptible to infection and other disease outcomes. This would be very difficult without an effective vaccine, but could be achieved by shielding of vulnerable groups, for example, the elderly, who would be at a higher risk if the virus is reintroduced. Engage community, help to define and accept the new normal by maintaining measures that were in place to stem the first wave, such as social distancing, hand hygiene, working from home, online training, trading, etc. Continue to advocate for carefully planned and executed public health approaches to epidemic control. Establishing and maintaining essential public health epidemic control measures, even after a plateau in cases and a decrease in transmission, is critical to preventing multiple waves of cases. The effectiveness of any one public health intervention to the exclusion of others is likely to be limited. Multiple effective interventions must be implemented at the same time to simultaneously reduce risk, reduce transmission, detect and isolate cases, and trace contacts. Second waves can be avoided by ensuring these critical public health epidemic control measures are effective, are scaled up, and reach all affected and at-risk population groups. So national societies are well placed to support some of these community level public health measures, and many have extensive experience in epidemic control. National societies can provide a critical workforce to scale these measures and are trusted voices in their communities to engage and educate communities. So national society activities we consider to prevent further waves include supporting health authorities to detect, test, isolate and treat every case and trace every contact through community-based surveillance, auxiliary support to mass testing, contact tracing and support to quarantine facilities and facilities isolating mild cases. Help schools, markets, health facilities and other essential places establish preventive measures such as hand washing points and patient flow to improve physical distancing and again promote hand hygiene broadly. Provide workforce to support screening at points of entry and points of control. Engage with communities. Communities must understand that life will not return to a pre-COVID normal for many months or possibly ever. They must be engaged in designing and implementing the measures that will remain in place in their communities to prevent a second wave. Engage in wide-scale risk communication and hygiene promotion before the suppression measures are released or relaxed. Advocate for carefully planned and phased approach to the end of lockdowns and transmission suppression measures. The government health authorities should lead, just a note here at the bottom to point out that the government health authorities should lead on laboratory capacity and testing of individuals, but systems to support these mass testing approaches require extensive engagement, organisation and community level activities, which national societies are very well placed to support. Now, just before we end, I just want to go on just a special note on lockdowns and similar measures. For contexts that have achieved a plateau in cases, primarily through physical distancing created by enforced lockdowns, rather than through public health measures to detect and isolate all cases and trace all contacts, the return to normal life presents serious challenges. In an ideal scenario, the transmission of the virus would be completely interrupted, or standard public health epidemic control measures would be introduced and scaled up to ensure coverage of the entire population before any physical distancing measures were relaxed. Shutdown measures, however, exact too high a cost on people's mental and physical health, their social well-being and livelihoods to be sustained for very long. The World Health Organization has advised that the following conditions must be met before communities can begin to slow the process of exiting lockdown and reduce the risk of a second wave. So disease transmission is under control. This is where health authorities know where transmission is occurring and the health caseload is manageable for the health system. Health systems can detect, test, isolate and treat every case in order to keep transmission low enough to prevent a second wave once physical distancing measures are relaxed. Contact tracing and isolation of all cases, which require an extensive workforce to trace any person who has been in contact with a positive case during their infectious period. Identified contacts must be informed, supported to stay at home or in quarantine, and followed up daily to detect new cases. Hand washing and hygiene promotion to prevent transmission caused by people touching infected surfaces. Wide-scale testing and screening to detect new cases. The risk of importing new cases are managed through point of entry, point of control screening, quarantine and rapid detection and isolation capacity. Hotspot risks are quickly minimised in vulnerable places, such as in nursing homes. Schools, workplaces and other essential places have established preventive measures, for example, hand washing points, spacing to allow continued physical distancing, screening measures, and that communities are fully educated, engaged and empowered to live under a new normal. Maintenance of physical distancing while reopening the economy to maintain a low level of transmission. So here are just some of the secondary impacts that could be felt from a second wave. Increasing burden on the health facilities, leading to their collapse. An increase in domestic and other forms of violence. societal tensions, grievance and blame, economic downturn, prolonged recession, loss of livelihoods and education, increased levels of poverty due to loss of income displacement, potential famine and other health emergencies on a vulnerable and exposed population, exhausted healthcare systems and lack of healthcare workers. So we come to the end of the webinar. We'll remain, myself, Dr. Abhishek and John and any of our colleagues in Geneva, we'll be happy to respond to any questions. So I'm going to hand this back over to Dr. Abhishek to just facilitate that, and then we'll go to John for some closing remarks. Thank you.
Thank you, Nick, for this very comprehensive. Maybe we need to. Okay. Hello. Nick, can you please turn off your mic? Okay. So thank you, Nick, for the very comprehensive presentation around the most talked second wave, and like how and what can be the potential impact of this second wave on us, and will a second wave will happen or not? What are the criterias, and how the Red Cross, Red Crescent can play a vital role in supporting their authorities to mitigate the impact of the second wave or the secondary impact of the once the lockdown measure or the movement control order is slightly lifting, etc., which we all are now be facing it. So now we have a good 10 minutes for some discussion. Like if you have any question, you can either raise hand and then ask question, or you can also type some question for any one of us regarding the second wave. So the floor is all yours for any question in regard to the basic situation that is happening in Asia Pacific, or any question regarding the second wave. I cannot see any hand raise, and the chat box is also, there is no question around that at this stage. But like if there is any question, I think it will be a good opportunity to ask or to clarify some doubts. Okay, there is one hand raised. Like Johanna, over to you.
Hi, this is maybe a little bit about being prepared, obviously, but has anyone been talking about getting some pre-positioned PPE ready? As we already know now that it has been quite a big challenge to get the needed equipment and getting the needed PPE. So has there been any further discussion over this? Because I'm now in China and we are already facing problems getting things out from here now. Not to mention that if the second wave comes, I'm expecting that we would be maybe first ones to experience that here in China. So has this been in any of the discussions on the business continuity, just to ensure that we're not repeating the same issues what we have faced on the beginning of this year? Over.
Okay. Johanna, maybe I'll take this question. I don't know if there is any logistic colleagues in the call or not. And as you already understand, like there has been a big challenge with the PPE for the response, and we are still struggling to get the right amount of PPE for the demand of different national society at this stage. But at this stage, we are discussing in Kuala Lumpur with the logistic team that there is a need to pre-position some of the critical personal protective equipment, but the challenge remains the availability of PPE at this stage, and at this stage we are still trying to fulfill the demand that is coming from the national societies who are primarily working on the health services. So here at this point of time, there is a more focus on how to respond and try to meet the demand of the national society who is currently doing the operation. But yes, definitely that is a big consideration for us at this stage, how we can have some preposition of PPE at Kuala Lumpur, so that if tomorrow second wave happen or any other pandemic happen, we will be able to give our supply at least the basic PPE in much faster rate than what we have experienced during what happened in China in the beginning, how we struggled with that. So that is already a big lesson learned, and people are aware. And then we are working hard to establish some of the supply chain and get something stored for the next second wave or the third wave or any new pandemic as such. Now there is also a question from Gopal. Maybe this might be for Nick. It is primarily how we can envisage this in the business continuity plan, primarily with the potential second wave. Nick, would you like to address this question around the second wave and the business continuity planning?
Yeah, that's a really good question. And as you know, we do have the Business Continuity Planning Task Force group. Ideally, business continuity is not just limited to the COVID outbreak. In any operation, and particularly how we work, there is a requirement for us to continue those operations in any situation. What probably the second wave raises concern, and especially knowing that the second wave can have a greater impact on infection and also fatalities, how does that leave us in being able to respond, particularly when the secondary impacts could really have a huge impact on movement, on how we work, the services that are available. All these are going to raise issues on how do we respond. From that, I'm just wondering if Andreas is on the call at all, because maybe Andreas can give us an idea on what's happening with the current BCP and considerations of what will happen, because it's already included in that. But understanding how the secondary impacts can really, overextend, I guess, on the levels of services. How can we respond and just provide those basic essential services for people who are affected by the COVID? And I just saw Jess is there. So yeah, Jess, if I could bring you in on that.
Yeah,
that
I mean, in
well,
case Andreas is not here to answer the comment, he's the leader on the BCP, but your business continuity plan should be a living document. So whether it's you're facing an increase in cases, a decrease, or a second wave, you should always be constantly adapting it so that it is relevant to the situation that you may be facing. Likewise, your risk analysis should also be a living document and should be adapting to whatever it is that your specific country or countries are facing. And you should be also reconsidering the scenarios. You might also find it useful to look in the Asia Pacific Emergency Plan of Action at the scenario analysis there, which is based upon the ACAPs. It's more of a global kind of assessment of where we might be, but there's some useful information there that's relevant to us in terms of how things could play out in various countries and what we might need to consider from a programmatic perspective. But I think the business continuity is also something that's important to continue to develop and grow based upon our knowledge of the situation. Over.
Thank you, Jess. Now I can see Ritva also wanting to ask some question. Ritva, over to you.
Yes, good afternoon from Yangon to everybody. This is Ritva. This is more of a comment, I guess, and maybe a suggestion to engage with the people who are really dealing with the volunteer management. Now we are talking about second and third wave. We are talking about secondary impact. We are talking also about the regular programming activities. And as we all know, we are 100% dependent on our volunteer workforce. There are already some signs of tiredness, and we are still at the very end of the long run. So I'm just thinking if we could have a webinar just to brainstorm together with the people who are really engaged in volunteer management, how to motivate, how to support. It's very challenging at the moment because we don't necessarily even meet with the volunteers. We are working with them in a remote control manner and looking at it from a longer point of view. The same volunteers are also going to be impacted by the second and the third wave. The same volunteers are impacted by the secondary impacts and all that. So just a suggestion for a webinar to look into the volunteer management motivation issues. Over.
Thank you, Ritva. I think you have a very good suggestion, and we'll take into account this suggestion and we'll discuss with our National Society Development Team, which is primarily responsible for volunteer management, and maybe also a discussion with the psychosocial support SIRS, like how we can really have a webinar focusing around how to motivate volunteers in this difficult time, where we all are lacking that physical with the physical distance and everything is on remote and technological basis, and we have lost that human touch. So that is where we should come in as such. But I think it's a very good seminar. We'll coordinate and we'll come back to you on this. So there is one question from Mohammed Asik. I think it is regarding, is there any guideline that IFRC is now going to produce in order to guide national societies around the second wave? In this regard, I think there are some preliminary document that Geneva has already produced around the basic analysis of second wave and what we can expect from it. And as Nick has also presented, around few components where Red Cross can be really helpful in supporting their Ministry of Health on mitigating the impact of the second wave. So that is where it stands, but we can definitely take and have this query to our colleague in Geneva about the potential development of a concrete guideline to support national society to already think of the second wave and integrate that in their plan when we are still responding for the primary wave or the first wave of COVID-19 in many countries as such.
Maybe just to jump in on it, because there is a link between Mohammed Sadeh's comment and also Ritva's in terms of the amount of work the volunteers could be doing. Firstly, with Ritva, and I think that's such a good comment, but also what we've seen with the first wave and how the national societies work, how we've adjusted some of the program to lessen the need for volunteers to have that physical contact with the community. So measures such as designing the online learning, knowing that volunteers will be at risk should they come in contact or close contact. The classroom environment is also not deemed a safe environment in which to teach. And I think with moving forward on a second wave and developing that guidance, so we have a guidance document that was sent out to national societies on how they can work, understanding where our strengths are in the Red Crescent movement, where is the greatest impact we can have in trying to contain and mitigate the virus? Are we going to be focusing more towards that sort of clinical, or are we going to work on where we know we can have a greater impact in preventing the disease at source? So we'll have learnt a lot from that first wave. We know its impact. We can imagine that the impact in the second wave can be more severe based on our knowledge from the 1918 pandemic. It may eventuate, it may not, but that shouldn't stop us in preparing. And I think what Johanna was saying earlier on, we know we're going to need a lot more PPE. So now is the time, if it's not too late, to really start putting in those systems and putting in the resources that will enable us to respond quickly, if not to prevent that second wave. A document that I'll be working on, and it'll be drawing on some of the information coming from Geneva, is a guidance to national societies, but it will link in to how do we scale up and how do we respond, which has also been sent out to the national societies on what is their best point of entry to try and reduce the impact of the second wave, but also the impact of the secondary consequences from the second wave. Over.
Okay, thank you, Nick. Johanna, you have any other question? I can see your hand raised. Or it is...
No, I do not. I don't have my... Oh, sorry, I have to lower my hand, sorry.
Yeah. Okay, is there any other question that I have missed, like someone would like, because we can take one more last question at this stage. Any more? Okay, if there is no more question, like you always know, like these are the 3 major websites we always promote in things like Health Help Desk, where we can get all the materials around the health that they have developed from Geneva, from different regions, from other organizations. And also you can ask your specific queries or specific guideline that you need or specific advice you need from the IFRC colleague. And we promise to get back to you within 24 hours of your query. And then also there is IFRC Go platform where we have that informed risk index is there, and also some good analysis of the current situation of COVID-19 plus different materials, dashboards, etc. from different sectors as well. And finally, the Asia Pacific dashboard, which is updated every day in the morning, and then where you can find the particularly how the virus is behaving in the region. So these are the 3 website or the resource center that IFRC has developed for the National Society. And I do hope like if you can visit these sites and maximize the information given there would be really helpful. And you can also come back to us if you need some more information that is not there, that will help you to implement the work that you have been doing in mitigating or suppressing the impact of COVID-19. Now I would like to give the floor to John to wrap up this meeting with some key messages and thanking everyone for their participation. Over to you, John.
Thank you very much, Abhishek. Can you hear me? Abhishek? Hello?
Loud and clear.
Excellent. Okay. Thank you very much indeed. And thanks, Nick and our colleagues in Geneva for the analysis. Very, very clear. Obviously, thanks to everybody who participated. I think at one stage over 50 people. So I've just got a couple of aspects. Much has been discussed and much has been also delved into during the question and answer session. But I guess it's hard when you talk to family, when you talk to colleagues, when you talk to friends, that you say that you know it probably may get worse before it gets better. And I think, you know, we've mentioned the psychological effects, but I just want to mention that from the WHO perspective, they are saying that a second wave is more or less inevitable. So, I mean, we do realize that this is a very real threat. The comment from Dr. Mike Ryan, last week was that this virus may just become another endemic virus in our communities. So the disease may persist in countries at low level, especially without the capacity to investigate clusters and such like. But I think what is important here, 2 or 3 main points here. Number one, there's been a lot of institutional learning in the course of the last 4 months or so. So, I mean, national societies, the Federation indeed, governments are better prepared in regards to the measures that they put in place. I think this is really important. I think as an organization, we have learned a lot, but I do take the point, of course, of Joanna and other colleagues saying that we need to have material and equipment on the ground as well to prepare ourselves and to prepare communities for the almost inevitable second wave. But I also think that Red Cross, Red Crescent will have an ever more important role to play in the event of country level and of regional level for second waves, because apart from the health effects, there'll be a tremendous amount of frustration and anger with government and authorities. And I think Red Cross in the humanitarian space and our efforts around humanitarian diplomacy and advocacy, we will have a huge role to play in terms of our advocacy, particularly for excluded groups and vulnerable groups such as migrants, the urban poor, and those who have lost their livelihoods. So outside of health, we will have a tremendous role to play in advocacy. Another important thing I just want to say in general for these webinars, as I said, 50 people, primarily in the health departments or the health specializations in the different national societies, and of course within the Federation. But what I would like to ask is somehow leading to the question of RITVA and volunteer awareness. I'd also like to think that the participants, particularly at national society level, will share the learning coming out of this webinar, because it is extremely important that management and other colleagues working in the different departments are also aware of this analysis, so they're better prepared for what may eventuate. So perhaps we just need to work out a better system in terms of of filtering down and up this analysis. Abhishek has referred to some very good websites we have, but I do encourage everybody at this webinar to engage at the National Society, at your National Society level, and please create the space to share the analysis so that everybody is informed and we can start a real debate around how to prepare ourselves better for what may be just down the road in terms of a second wave. So thank you all very much indeed. Point taken in regards to some of the needs for subsequent seminars or webinars on volunteer awareness. If anybody has got any other ideas in terms of areas that they would like us to delve into in a bit more depth and detail, please reach out to myself or Dr. Abhishek and we can organize that. So that's my few minutes. Thank you all so much. Thanks again, Nick, and thank you, Dr. Abhishek and Jesse and all of the participants. And we look forward to meeting up again next week. Thank you all and have a nice evening.
Thank you all. Thank you very much. And we'll share the presentation.